All right, well, we are going to get started. And the next section is really talking about the stroke unit of the future. We're going to talk about the Johns Hopkins approach to how we're innovating and advancing our hospital system. But the whole talk is intended to really inspire your own thinking in terms of where your stroke unit is and where you're headed. There we go. All right, so I don't have any relevant disclosures to announce, but I am always very appreciative of the research funding that I've had in the past to both inspire our thoughts and motivate and activate us to move forward every day that we're giving stroke care to patients. I'm going to start my talk by saying this work that I'm about to talk about really is because of the village of awesome people I get to work with on a daily basis. Many whom you've met today, others you'll meet in a little while. But to say that it takes a village is a real understatement, and I really have the best. So appreciation to all the people that contribute to this work in both small and large ways. So we're going to start just by orienting us to where we are in space. What we're really talking about for the next hour or so is this hospital phase of the trajectory of stroke care. As all of us who are stroke lovers and people who are really working to change the face of stroke care, we know that stroke care occurs really on a continuum. The ideal would be if we could all get on board and stop any stroke from ever happening again in the future. But while we are still having people across the globe with stroke, at approximately every 4 seconds, someone in the world is having a stroke, we'll have to turn our efforts into what happens then when the patient hits the hospital door for hyperacute therapies. But our session will be really what happens in this early recovery phase, the phase that is the first few days and weeks after stroke while the patient is transitioning from hospital to their next point of care, whether that be back into the community or to a rehabilitation location. And I think the question that I'm constantly asking us and our team on a daily basis is, are we optimizing the patient's clinical status? Are we doing everything that we can to reduce disability by what we do with the patient on a daily basis? Now, we last year at this conference had Dr. Corbett visiting us for the keynote address, and he spoke all about brain repair and what we know about the brain's ability to repair itself. And this is a slide I like to display basically with every talk that I give, reminding us why it is that I feel that those first couple of days and weeks after stroke are really critical. As we've heard, the critical period of brain recovery might be on the order of weeks, the first few weeks after a stroke happens. And when you think about your sickest of stroke patients, often those patients with hemorrhagic stroke or the patients with comorbid illness and ischemic stroke, they may spend a good portion of that critical period in the hospital during that time. So while models of stroke care have typically not included a lot of early recovery activities in the daily hospital care of the patient when they first arrive to the hospital, we have to start changing our model of thinking to say that we really must start thinking about it there, else we miss a window of opportunity. Now, we know that revascularization procedures like thrombolytic therapy and mechanical thrombectomy, there's no arguing that they are critically important and have a very high possibility of helping people fully recover after stroke. We know those procedures are time sensitive and many times resource limited. So depending on where you are at the time of your stroke may or may not contribute to your ability to receive those revascularization procedures. And when we look at the even high resource countries across the globe, only about 10 to 15% are eligible to receive revascularization procedures, perhaps because of the resources in their area or other medical exclusion criteria. So we have to always keep the mission, the foot on the pedal, to get people to have more revascularization procedures where possible. But I would ask us, what happens to the 85 or 90% who are not eligible for those treatments? What are we doing every single day for those people? First, I think that we have to really not underestimate the power of complication reduction. So I'm just going to spend 1 or 2 slides on this concept, because while we're talking about innovations in stroke system care and really the vision forward of what could be the universe of possibilities, I never want us to miss the fact that many of the things that will help every stroke patient really are right there available under our fingers. So preventing early complications, we know, is one of those things that we can do by having a stroke center that is ready to think about early brain repair and recovery. There was a beautiful study, small but beautiful, in 2015 by a group of people in Sweden. And they basically looked at the cohort of stroke patients and what kind of complications people were having in the first 7 days of stroke. And then examining the association with long-term outcome. So we see from this colorful grid that if a patient has any number of complications, their long-term functional outcome will be disrupted. So for example, if a person has a recurrent stroke in the first 7 days after their original stroke, they have increased odds of worsened outcome, 7.5 increased odds of worse outcome just by having that recurrent stroke. So it's no wonder that we have a lot of attention to diagnostic tests and hustling to try to figure out why the patient has had that stroke on that given day and try to make sure that the medical management is perfectly planned to reduce chance for a second stroke, because we know that in itself will just be a tremendous barrier to overcome. We know if a patient has a chest infection like pneumonia, they'll have a 3.5 times increased odds of worse outcome at 3 months. So what we do in those first few days matter in terms of just complications alone. Now, we have heard that there are some weapons against stroke, thrombolytic therapy, and mechanical thrombectomy, but I want everybody to think of their stroke units where patients are treated in the hospital as an additional therapy. We heard that the number needed to treat for TPA is on the order of 11%, up to 11 to 14 number needed to treat. And the number needed to treat if a patient is hospitalized in a place with standardized protocols, educated nurses who are focused on delivering stroke care, we know that the number needed to treat is on the order of thrombolytic therapy, so a very potent weapon. We also know that the guidelines put out by the American Heart Association recommend that it is recommended that early rehabilitation for hospitalized stroke patients be provided in environments with organized interprofessional stroke care. Now, I would say that it's great that these words are included as Class 1 Level A evidence in our guidelines, but I would say that the loose terminology and the ability to implement this with any consistency in hospital settings has been a real challenge. And that's going to be sort of the focus of our innovative talks moving forward. Now, we also know from 2004, a study long ago by Julie Bernhardt and colleagues, that while we know that exercise is a cornerstone for recovery after stroke, we also know that the hospital setting, the patients are spending a lot of time in bed, not moving, and alone and isolated. And we replicated this study by doing an observational study on our unit to see if in this day and age we were still having the same problem. And we were disappointed in ourselves to know that, yes, indeed, 67% of patients are spending their time all alone, isolated in a time period that they're having emotional adjustments to a stressor. And we know that a large percentage, almost 3/4, are still in bed most of the time during the daytime, even in a large comprehensive stroke center. So we have a lot of work to do, and thus we embarked on our mission to start sort of changing that environment and looking at opportunities to innovate and improve our stroke care. So we have been envisioning this as the stroke unit of the future. We want to really think of it in 3 domains that have a lot of high power to influence us changing our ways and not being stuck in our old practice ways. Our trifecta is we needed the people to be highly expert at what they're doing and thinking about recovery activities from the moment a patient arrives. We needed to make sure that our technology was up to par and even innovative beyond what we already had. And we needed to make sure that our environment itself was really ready for every patient to recover to the best of their ability, so that what we do today really has the opportunity to influence someone's outcome later. And then you'll see surrounding all these 3 domains are data, because without knowing what we're doing and how we're doing it, we'll never be able to improve and move our system forward. So here was how we started thinking about it. Can we fit recovery into the standard stroke hospital? And I will say that when we first started talking about this years ago, here were the common responses. Oh, these patients are too sick. We're a referral center. We have a lot of patients with large artery strokes, large cortical strokes, hemorrhagic strokes. They're too sick to really participate in activity that has any meaning. The next thing we heard all the time is there's no time in a patient's hospital day. They have a lot of diagnostic tests to have. They have treatments that need to be delivered. There's a lot going on, and there wouldn't be time for any meaningful recovery activity. The next thing we hear frequently, both at our own facility and every hospital that I visit to talk about their stroke centers of care, is we definitely don't have enough staff. It's impossible economically to think of hiring enough therapists to really begin to have a therapeutic recovery system in those first few days after stroke. And then finally, many people just say, hey, the goal of the early part of stroke care is really just diagnose and discharge the patient so they can start thinking of their recovery elsewhere. And so these are really some of the common themes that we hear as we talk to people about what activity levels their patients are achieving at their stroke center. And the little schematic, the green schematic to the right of those bullets, is really our attempt to use some engineering design theory to look at how our patients were actually spending their time, to figure out if we could congregate key moments together to introduce recovery activities that were meaningful and undisrupted. So we really started with a system assessment to see if there are stolen moments that we could put together to, in fact, even think of implementing any recovery activities. Now, the next part of knowing your system was the critical first step. But the second thing is really knowing who's at risk for early activity. Who might this not be safe to consider? So we know that in the AVERT trial, that was the largest international multi-center study, there was a question about whether or not very early activity, like in the first 24 hours after stroke onset, would this actually be helpful or detrimental? And the trend was an association towards worse modified Rankin, worse functional outcome at 3 months for those patients who were in the very early group within 24 hours. So while there are design issues and things that we could really question about those data, this really did help people to really worry and pump the brakes a bit about what kind of early activities we were implementing. So I would just say, for the most part, we don't start very aggressive early recovery exercises in the first 24 hours, but instead have a very progressive approach to how we are going to manage patients to get early activity. There are groups of patients, though, that are high risk, and those should be tucked into the back of our minds so that we're sure that we especially monitor those patients carefully as we're thinking about therapeutic activity in the early few days. So if your patient is having a fluctuating neurologic exam, meaning anytime before or after or during your session, they look like they're having neurological worsening, that's a time to really stop and think to ourselves, perhaps they're having a perfusion problem to the brain that our exercise is not helping. And we know that the main priority in the first few days is being sure that the stroke size doesn't actually enlarge in the first few days. We want to make sure that the patient doesn't have evidence of intracranial hypertension or cerebral edema. Is your patient at risk for brain herniation? In that case, we don't want them doing activities where they may hold their breath, increase their intrathoracic pressure and jugular pressure. So you want to think very carefully about the patient who has a large cortical stroke who may be developing edema, or the patient with hemorrhagic stroke with the same. Now, patients who have comorbid conditions for stroke also have comorbid conditions for heart attacks and myocardial infarction. And therefore, it is not uncommon that patients will have associated cardiac issues simultaneously. So if your patient has an aortic dissection or is having an active MI or myocardial infarction, we may need to slow our activities and use more in-bed approaches. And then we need to remember that our patients can have large fluctuations in their hemodynamic status. In fact, this little table on the right that was intended to be small and not red is to tell us that about 20 to 25% of all stroke patients will have some degree of dysautonomia, cardiovascular dysautonomia, meaning that they will not be able to regulate their heart rate and blood pressure responses during activity appropriately. So we really need to keep our eye on those activities for patients who will be high risk for early activity. So once you think about the safety profile of who might be at risk for early activity, you can then start to think about what activities could be safe and how we could bring those to meaningful levels for patients. So in our facility, we started with the most critical of the patients in our neuro ICU, patients where patients were very sick with very severe neurocritical injury, as well as comorbid conditions. And we asked ourselves, could we inspire every person who's working with the patient, nursing staff, techs, physicians, could we inspire everybody to get involved with a progressive mobility algorithm that's really driven by at all-inclusive entry criteria and clear stopping criteria. So a patient who was able to sort of raise the head of their bed during one session, maybe 2 hours later, we had the patient sitting at the edge of the bed. If they were able to tolerate sitting on the edge of the bed, maybe a few hours later, someone would try transferring the patient to the chair. Next patient who comes into the room, well, could the patient stand for 1 minute? And so we really wanted to see if, when everybody got involved, if we could have a progressive algorithm that really increased everybody's awareness of the need for motion and mobility, and have the staff all get involved in such a thing. And Betsy Zink, who you're going to meet in a little while on our panel, was really responsible for inspiring all the staff and getting people into this sort of frame of mind where we're all part of the activity algorithm and mobilization. Now, we realized that there were going to be a proportion of patients who needed to have activity while on bed rest. So here are some pictures of some of the tools that are used. Cycle ergometer that could even be used with a patient with poor cognitive status. Someone who's in a coma would still have passive movement of their legs using this cycle ergometer. And as the patient became more awake and interactive, it would become possible that the patient would actively cycle in bed. The same device could be converted for upper extremity movement for patients who have weakness in the arms. And then we can't forget, because of the degree of orthostatic hypotension and dysautonomia, we needed a tool to help our staff safely move patients from laying to standing, but in a more incremental, step-by-step way. We know that a person going from bed rest to completely standing up might have higher risk than someone who's progressively verticalized. So we started with a very easy, no extra investment algorithm that might help people to get involved in the scenario. We next started to talk about, well, why can't we have an enhanced therapy model where we have more therapy contact with the patients for both impairment and functional recovery activities? And so this was a huge effort by a large army of people. So it's almost unfair that I put a couple of pictures on, but I would be remiss if I didn't have my partners at the start of this imaged. Annette Leveza was one of the administrators who helped make this possible. And April Pruski, one of the physiatrists who really helped us take this off the ground. We started to put into place a model where therapists would see patients 2 to 3 times a day. So every discipline, speech and language pathology, occupational therapy, and physical therapy, each would see the patients 2 to 3 times a day for short sessions. And that really resulted in patients getting much more focused therapy within the first few weeks after stroke, such that patients were receiving really 2 hours of standard therapy on our unit per day, 7 days a week. This has resulted in a whole shift in how we think about recovery being included in right alongside our diagnostic and therapeutic tests of our unit. But we really have started to notice that there is a slight decrease in length of stay when we have included this model, when we did a quasi-experimental comparison pre and post intervention. And in our most recent assessment, we saw a trend to 3-month modified Rankins being improved. So patients who were exposed to this enhanced therapy model getting more therapy in the early period actually started to look like they were doing better or trending so for the long term. So this, a lot more to come, and we had a paper published about this recently to really kind of summarize our findings. But we found that it was possible, it was safe to have a lot more therapy in the early period, especially under the wise guidance of our neurotherapists, and hopefully we'll have longer standing results for outcomes. Next, we wanted to say we understand that there are settings that will not be able to have extra therapists hired and working with patients in the hospital setting. That's just a reality of our healthcare system across the globe. So we really wanted to talk about, are there other tools that could help patients to independently be motivated to sort of work on their recovery and activity in the first few days after stroke? We have tried many tools across our stroke unit, from the basics of a Wii system where we look to see if people could just play on a regular Wii game. We made an algorithm with our occupational therapy team that might look at patients' deficits and match games that could be useful to improvement. We have swallowing games to really promote better swallowing after stroke. And we have multiple systems to really look at how the upper limbs can be exercised in the first few days, including the bimanual arm trainer that you're going to hear a lot more from Dr. Raghavan tomorrow, and the MindPod game, which was mentioned by Dr. Krakauer and Omar Ahmed, who developed those together with the Kata group. We basically wanted to see if any level of these games could motivate patients to jumpstart into activity. Could patients do it independently without the presence of a really highly trained, highly specialized clinician with them? Is there a way that family members could eventually learn how to help their loved one play, so that in the middle of the night when people are awake and worried, instead of just laying in bed, they could work on their recovery? We built an immersive treatment room in the center of our stroke unit that's pictured here, which is a place that's really an escape from our stroke unit, a place where you can go in and have high dose, high quality movement therapy using the MindPod game. And we have studied in a pilot of 77 sessions what happened to patients when they were exposed to such a room. Could they do it? Did they like it? Our average NIH stroke scale score was 7 for patients, so kind of on the mild to moderate stroke size. And we found that even with patients receiving in our unit 2 hours of standard therapy as a baseline, even more on some days, patients were able to achieve an extra 27 minutes of completely active time on task using the upper extremity. Now, the patients were interrupted sometimes, but only 18% of the time, and we did not find any early safety issues of line dislodgement, pain, hemodynamic instability. So all good signs for our pilot to be expanded. This is just a couple of other pictures of the immersive MindPod room, which is really a place where the sound is really soothing, the lights are soothing, and the game is really a large-scale game that's projected to make the patient feel as though they're escaping from the hospital unit for a bit of a break and some really meaningful, high-quality, high-intensity activity. So, so far, it looks like it's very positive to bring such a unit to the stroke center, and we'll be measuring longer-term outcomes as we go forward. This is the team that has a protocol in place where we're now randomizing patients to receive these treatments, and so that we can compare and contrast the outcomes. And if your center is interested in such a thing, there are ways to help that we could share our protocols so that we can make sure that the patients get the most amount of early activity as safely as possible and in a standardized way. Now, the worry that patients had that, there's not enough time, you're supposed to be reducing length of stay for hospital patients, you're supposed to, really be sure that the patient gets out of the hospital to then go to the rehab center. That is all true. Nobody wants to keep patients in the hospital any longer than they need to whatsoever. So we approached a project with the School of Engineering to see if we could have a predictive model to say, well, which patients will be in the hospital for a short period of time versus a long period of time. And that way we could script the activity treatments to that time limit. And using one of their computational models, we really found that with pretty good specificity, we could predict who was going to be discharged before the 7-day point and who would be discharged after the 7-day point. And that really allows us to do a lot of good resource allocation between who gets early activities, who might be enrolled in longer protocols in the hospital, and really just helps us with our sort of resource dissemination. So there are a lot of possibilities for this using very simple parameters to help us predict who's going to be in the hospital for a longer stay, which may in the end tell us who's at risk for complications. And I do give all the credit in the world to this really energetic engineering group that we worked with. And it was a really, really fun project that we worked on. So again, here it is just showing that the area under the curve is 0.825 for us to be able to predict time of hospital stay. Now, there are a group of us who are all looking at multiple physiological parameters, things that help us predict whether a patient will worsen in the early period, recover in the early period. There are devices that we have that we send home with the patient, including a stroke app and wearable devices, so that we could help monitor some of these very important parameters that we mentioned, both in the hospital setting and as patients transition into their home setting. We don't want to lose those important variables as things that could inform us in terms of stroke recovery and a person's response to exercise. It would be terrible if while a patient's in the hospital, they look very stable hemodynamically, but they go home and start exercising and then have a lot of perfusion problems or hemodynamic instability. So all of these different tools that we have, we're testing their worth, the value of whether they're going to be helpful to patients in the home, in the hospital unit only, both, or neither. And there will be a lot more to come in the future. But just to say that there are really, really important physiologic variables that we need to keep track of and help patients modify as they begin exercise treatments. Now, the last section is can the stroke really be a healing place? Does this have to be a place where it's just diagnostic tests? We try to push a few people into early exercise and then discharge. And really, I really like these couple of pictures because we have to really step back for a moment and remember the shock that comes with having a stroke. A stroke is a very sudden phenomenon. A person can go from having very independent function and active life to yesterday and then today be dealing with the consequences of a stroke that could be language dysfunction, inability to move, cognitive changes. So I really always like to think of Kubler-Ross and the stages of grief as we're thinking about our first few days after stroke and stroke management. I like this little blue cartoon that I took from the website for Kubler-Ross's stages of grief, reminding us that there are different phases that people will go through. At first, patients may or may not want to engage in early activity therapies. They may be bargaining that, why is this happening to me? And just, try to figure out the meaning of all this. As we were talking about multiple times today already, there's depression associated with stroke and emotional changes that come with this sort of thing before finally reaching acceptance. But I really especially like this this picture on the right, which is really the same thing. It says stages of grief, which is Kubler-Ross. But are we really addressing the emotional needs when the patient's sentiment is not linear in any way, but instead this tangled mess of emotions where, in one day you're really motivated and ready to jump into restorative therapies. The next day you're in denial and angry and not wanting to participate. And how are we going to manage behavioral interventions that really have to run the course amongst all these emotional changes? So we really wanted to really explore our stroke unit to see, is it a healing space amongst all of this different emotional charge that patients and their loved ones will feel? So we've really asked ourselves a few important things. One is our space stressful? Hospital clearly would be a stressful place, but can we make it less stressful? Is the person with stroke informed enough? Do they know what's going on enough to feel like they are armed with knowledge so that they can kind of move through these emotions and get to strong acceptance points? Are we addressing the emotional needs of patients? And not just for the patient, but for the care partner. And then finally, is the care partner ready? As across the globe, we're looking to decrease length of stay. We have to look and make sure that we're really readying the care partner for their role in recovery. So the last few slides are just a couple of examples of things that we're doing to really kind of make our space more of a healing space. So we started with some pilot funded projects with the Peabody Institute to look to see if bringing music to our institution could help change the stress level of our environment. And this was a pilot of 122 subjects, 84 of whom were patients and 38 were staff. And we came in the evening shift so that we could see if deploying music before bed could sort of help patients with their perceived stress and perhaps even help with sleep and blood pressure. And I would say qualitatively, patients have reported that they felt transported. They weren't feeling like they were in a hospital anymore. Several patients reported that they felt that they had a private concert that others might only envy to have because the Peabody is such a reputable institution, and that made them feel special. And visitors reported feeling a lot less stress at a time that they tell us that they're just sitting, wringing their hands at the bedside. The music was a welcome distraction to reduce stress. Quantitatively, we see trends toward lower blood pressure. So patients before the intervention of music had blood pressures that trended down after the intervention. And staff reported reduced unit noise. Pre-intervention, on average, the unit noise was noted to be 8 out of 10, which is a high level of noise. And after the 45-minute music intervention, the average reported noise was 4. So I would say there's high potential to look at your healing space for both the patient, their care partner, and staff. And then next, we've been looking at multiple ways that we could bring the family into early stroke care. And here's Betsy Zink with her poem project. This was a study to see if patients were really ready to get involved in early activity programs. Would they be willing to help people with repetitive movements of their limb? Would they want to jump in and help encourage somebody who is using a cycle ergometer or a tool to help expedite recovery? And this is a qualitative descriptive study of perceived early mobility. We wanted to know if families thought they were too sick to progress forward. It was conducted in the neuro ICU, so again, with the sickest of the sick, and we really wanted to see what patient response was to the idea of them getting involved with early activity for their sick neurocritically ill patient. So we're in the analysis phase still there, but there should be a lot learned from the lived experience of the care partner. On the right of this slide, we a couple of years ago implemented what's called structured bedside rounds. This was really interprofessional rounding at the patient bedside so that the patient and care partner would not only hear the decision-making that comes after a stroke, but also participate in the decision-making to both educate them, empower them with knowledge, and really emphasize the things that are important in terms of both stroke prevention, stroke treatment, and stroke recovery therapies that were being discussed. Overall, this intervention improves the accuracy of information being relayed. It improves trust with the clinical team between the patient and the clinical team. And it's proven to be highly efficient in that the number of minutes to round in a typical way, which might be outside of the room and then go in to kind of discuss with the patient the plan, it actually proves to be time efficient to do all of that in the room with the patient. So really an empowering way to bring information to the patient at the bedside and their care partner to be sure that they feel part of the team and know that the self-management of their health will be important moving forward as patients leave the hospital. And then that patient and care partner research will be added into our J-STEP program, which was really devised to ask the question, can we extend this stroke unit care that shows good outcomes for patients? Can we extend the stroke unit care to home and maybe even see similar benefits in terms of the number needed to treat if we extend the stroke care that is proven to have good outcomes for patients in the hospital? What happens if we send that sort of same resource home with the patient through a virtual experience? So the cartoon on the left was the first iteration of our J-STEP program, and this was a collaborative effort with our colleagues in the physical medicine and rehab department. We wanted to devise a three-part visit scheme where the patient, once they're discharged home from the hospital, would be seen quickly by a combined stroke specialist and physical therapist in the first visit. During that visit, they would be really focusing on safety of the patients and whether the stroke recovery and therapeutics are behaving as we expected. The next visit is visit 2, was intended to be a combined visit with physiatry and occupational therapy, here to again check to be sure that our functional treatment plan was as optimized as possible. Were we giving the patient the right therapies that they needed for rehabilitation? Then the third part of the visit was an intensive education session where the patient and their care partners would meet with an interprofessional team to really emphasize important education about stroke prevention and treatments of risks. So that was the first iteration of the J-STEP, where we had this three-part series, and we did see very clearly that the bar graph, the line graph on the right upper area, we did see clearly that our blue line, which is the Johns Hopkins Hospital, had significant increase in the proportion of patients who are seen within 30 days from a hospital discharge. So we had high success there. We had patients that would have previously been lost to follow-up, never made it to their follow-up visits, or seen just too late to help them with complications, were seen much earlier. Now, we learned, though, during that first iteration of J-STEP that actually some patients felt that there were too many visits and that it was a little bit overwhelming. So we've moved to a 2.0 version of J-STEP that uses the visit number 1 as the triage point for patients who have any issues that are bubbled to the surface, who need different types of therapy. We do rapid referrals for therapy to get people started. If patients have any issues that are social work needs or case management, we do rapid referrals to the case management team. So instead, we use the first visit as a triage, and still the third visit is with the education program. So to date, we've seen a total of more than 750 patients. The time to first visit from hospital discharge is about 8 days on average, and about 88% of patients complete that first visit, which is a very high show rate for clinic follow-up. And our hospital readmission rate is down to 8% from a national average of 12% after stroke. So a really great program to keep people after stroke engaged and their care partners joined in. And this is just a picture of Amelia Tenberg, who's really the tour de force nurse practitioner who runs the J-STEP program. Some of the things that we've talked about during the J-STEP education session and just what it looks like to be invited to the session. And I would encourage anybody across the globe who wants to extend this virtual class to any of their stroke patients, please email me or get in touch after the conference, and we'll be sure to put your stroke patients on our list for invitation to the stroke education. I think the more we reach with this information, the better. And then last slide before we get to our panel discussion with the group is, we do recognize that patients go home and cannot often leave home for their follow-up visits and their therapy sessions. So this is the STAR car, the stroke treatment and recovery car that is in place to really help take the stroke unit to the patient for those who have transport and mobility problems. This car, the patient can be wheeled in with a wheelchair. There are devices in there to measure patient recovery and encourage therapy and treatment. And so this is really just another way that was funded by the Sheikh Khalifa Stroke Institute to really try to take the stroke unit to the patient when they can't come for some of our scheduled activities. So now I want to end by saying, are you envisioning your stroke unit of the future? Are there ways that your people can take the next step forward in terms of their expertise? Is there any simple technology that you could bring to your center to just take your recovery care to the next step forward? And is your environment a healing space? And are there any steps that you could take forward to really make sure that the stress level is reduced, or that there is a more therapeutic approach on your stroke unit? And then finally, are there pieces of data that can help you know whether your stroke unit is really a therapeutic place and how you can grow moving forward? So, remember that the stroke unit itself is a treatment. And I want to know, how does your stroke unit promote success? Does it help with accurate diagnosis? Does it give access for patients to have revascularization and prevention treatments? Do you have algorithms to standardize your treatments that also include meaningful activity? Do you and your stroke unit avoid complications, because we know that in itself has a benefit for patients? And then do you give meaningful education about stroke prevention and stroke recovery for patients and their families? So these are all things that you can think of, all the domains to make your stroke center great and keep taking step-by-step progress forward. Because we really know that every detail matters. If a person has 0 complications, their outcome is great after stroke. But once you start having 2 or more complications, your odds of worse outcome after stroke are 4.5 times higher. So really think about complication management as one of the strategies that can really be helpful to your patients. So I'm going to end with our exemplar about International Stroke Center development. We partnered with the University Teaching Hospital in Lusaka, Zambia, and we know that many of our colleagues hopefully are online, although I know it's quite late there now. This is a tertiary care center in Zambia, about 12,000 admissions per year. Deanna Saylor, who's pictured here and with us, started a graduate neurology training program in October 2018. And we knew that this institution reported a high mortality for patients who were admitted with stroke. We received funding through the Forward NINDS Institute through an R21 to really think about a real question that could have a scalable intervention. So we've been really looking at dehydration rates, which we know are shown to have association with worse outcome if patients are dehydrated at the time of stroke. And we wanted to look at the infrastructure of the stroke setting of care to see if we could move the needle on stroke recovery and improve outcomes. So through some of these efforts, Deanna and the team there have done an extraordinary job of beginning to measure the outcomes that are happening, know what the mortality is for the institution there, train the neurologists to be ready to deliver stroke care. And I can't wait for the discussion so you can hear a lot more from Dr. Saylor about these efforts. And the key to this funded study is that it really gave us the opportunity to do a couple of really important things. One is stroke severity at presentation was measured such that we knew how to figure out who was very sick at the time of presentation and what the issues were that were coming along based on stroke severity trajectories. This funding allowed us to translate some of the scales that we have to really understand what our stroke recovery is like for patients who are experiencing stroke in Lusaka and Zambia at large. And so the ability to translate into local dialects and test the reliability of a modified Rankin score was one of the things that we're funded to do in this study. This study allowed us to understand physician behaviors in terms of practice, what treatment trends people were undergoing, and it also indirectly allowed us to know are diagnostic tests really available to patients so that we can understand the heterogeneity of stroke itself. And then Deanna will tell us a lot more about the education that's gone on. And we've included some research education formally for across the continent of Africa, but formally for the providers in Lusaka. So I'm going to leave this last picture up before I introduce the panel, and maybe Betsy and Deanna, you'll be ready to join us. And the real question for our conversation coming up is that we want to think about our stroke hospitals and are we where we want to be? I would say that I am never satisfied with where we are. I know we're making great progress, but we always have room for improvement here. And I'll be excited to hear more about your institutions for people who are thinking about their stroke centers. So without further ado, let me introduce our discussants. We're going to just open it up now to our group discussion. First is Deanna Saylor. She is a colleague and friend who I had the pleasure of training with and have the joy of collaborating with in terms of our stroke research. And it's just been great to see the extraordinary work that she does both locally in Baltimore, but in Zambia over the last few years. Dr. Saylor is an associate professor of neurology and the director of the Johns Hopkins Global Neurology Program at the Johns Hopkins School of Medicine. She and her family are living in Lusaka, Zambia, where she is the national director of the specialist training program in neurology at the University of Zambia School of Medicine. Under her leadership, she has developed the first neurology training program. And I can't wait for her to tell you how many neurologists have developed under this program from the pre-existing one neurologist that was the in-country neurologist. She is a neuroinfectious disease doctor and neuroimmunology specialist with special interest in neurological complications of HIV infection and multiple sclerosis. Dr. Saylor also specializes in global health and neurology, and her research interests include better understanding of neurologic disease burden in resource-limited settings, improving neurological education of both neurologists and non-neurologists in resource-limited settings, and improving the care of patients with neurological disorders across the globe. She has ongoing research collaborations in Uganda and Zambia, and has previously lived and worked in Kenya. Now, in the middle of your screen is Dr. Angel Sharif, who I'm sorry is not here with us today, but I just want to tell you how awesome Dr. Sharif is. She runs the Stroke Clinic and Stroke Transitions Education and Prevention Clinical Program, which she founded in 2014 at UT Health Institute of Stroke, Cerebrovascular Disease. She's an associate professor there. And I'm sorry that she's not here with us today because she was going to share with us some of her experiences of having patients move from hospital to home, especially those who have limited resources or perceived health disparities. So I am happy to collect questions for Dr. Sharif, and I'll be interacting with her after this session, but she's a force. And then last, I'm so happy to introduce our colleague, Dr. Zink. Dr. Elizabeth Zink received her undergraduate training in nursing from Towson University, her graduate degree in trauma, critical care, and emergency nursing at the University of Maryland, and her doctorate degree at the Johns Hopkins University School of Nursing and Health Services Research. Dr. Zink is a clinical nurse specialist in the neurocritical care unit at the Johns Hopkins Hospital. She has worked as a staff nurse, nurse practitioner, and clinical nurse specialist over the past 26 years in the areas of neurosciences and stroke, managing clinical care, research, and education at the patient, staff, and systems level. She has a track record of leadership and quality improvement efforts, organizing interprofessional teams, and translation of evidence into nursing practice. Her research interests focus on applying biomarker measurement of early rehabilitation interventions in stroke and neurocritical care, and exploring the effects of team performance on stroke patient outcomes. And if there's a single person who has really influenced the system of neurocritical care and early recovery, it's Betsy, and I'm so glad to be partners with her. So let me take down my slides because I feel all out of sorts, not able to see you all. There we are. And we're going to just open it up. And Deanna, Betsy, welcome. I feel like I've talked a lot, and I'm so glad to see you guys here, and really just start opening the discussion about any early thoughts from sort of watching those slides go by. Deanna, you're going to be able to tell us a lot of stories about what you think of when you see these sort of initiatives in Baltimore, Maryland, and how you think they translate to Zambia or what barriers exist. So Deanna, maybe we'll start with you.
Sure. Thanks so much, Mona. Thank you for the opportunity to be here and share about our work in Zambia. I think when I listen to your talk, the thing that really sticks out to me is the fact that stroke centers themselves are a treatment, and that they are of an equal magnitude to the thrombolytic therapy and thrombectomies and acute interventions that we have for stroke. And I think that's particularly important for those of us that are practicing in resource-limited settings where, in Zambia, we don't have access to TPA, we don't have the capability to do thrombectomies yet. And so oftentimes people might feel like, well, there's nothing to do for stroke. We don't have the therapies that everyone talks about. But in fact, there's no reason that you can't have a stroke center when you don't have those acute therapies available. And so our work right now is really focusing on how do we develop a stroke center in the absence of those therapies, at least at this point, and still provide that really important and impactful treatment for our patients, even when resources don't allow us to do some of the acute therapies. So I think that's one thing that I hope that everybody, no matter where you are, can take away, is that the stroke center themselves should really be thought about as a treatment that reaches every single patient with a stroke. And that we can really improve outcomes by making sure we've organized stroke care and protocolized stroke care in order to optimize outcomes for our patients.
That's awesome. So give us some context, tell us what it's like for a stroke patient who comes to the hospital there in Zambia.
Sure. So as you mentioned, so I moved to Zambia in 2018, so almost 5.5 years ago now. And when we arrived, there were a few expatriate neurologists here that provided limited clinical care. We're primarily doing research, and there were no Zambian neurologists. And in the past 5 years, we have fully trained 9 neurologists, and we have another 10 neurologists in training right now. And this has really already allowed us to make huge gains in stroke care for patients. So there was a study shortly before our training program began of stroke outcomes at our hospital, and in-hospital mortality was about 45%. So almost half of stroke patients died in the hospital. And in the subsequent work that we've done since we implemented the neurology training program, we've seen that number cut in half. So our current mortality has been 22 to 24% in the studies that we've done since 2018. And so we were able to make huge gains just by having neurologists in the hospital with that specialized approach to stroke care. But currently that does not include a stroke center. So our patients come into the emergency room. There's really no fast track or prioritization of patients who present with stroke at this point, again, because we don't have time-sensitive therapeutics available for us. And so they may wait 3 or 4 or 5 or 6 hours to actually see a doctor. Once they are admitted, we do have a CT scanner at our institution, but that generally has to be paid for before a patient can get the scan. So while most of our patients, about 85% of our patients, end up getting CT scans during their admission, very few of them get that in the first 1 or 2 days. So we're often making decisions to manage stroke without really knowing if it's a hemorrhagic or an ischemic stroke. Once they're admitted to the hospital, they spend a day or two in an area that we call the admissions wards for new patients getting stabilized. And then they move to the general internal medicine wards. Currently, there's about 6 different internal medicine wards, and our patients are scattered across all 6 of them. So there's no centralized place where they're cared for. And then, we face a lot of challenges. Our beds don't elevate. So even elevating the head of the bed to prevent aspiration can be a challenge. We don't have enteral feeds. And so if we put an NG tube in someone, and we're depending, and families provide food for patients. And so we're depending on the patient's family to figure out what kind of food can go into the NG tube and hopefully still meet nutritional requirements. We only have a few physical therapists on all 6 medical wards, and we don't have any occupational or speech therapists. And so that kind of multidisciplinary approach can be a real challenge, just because of the limitations in a lot of the other disciplines that are really required in stroke care. So we face a lot of challenges, but we're actually moving towards, we have a meeting in 2 weeks with all the stakeholders in the hospital. So radiology, emergency department, nutrition, rehabilitation, neurology, neurosurgery, even cardiology, to help us get more echoes on our patients and such, to really plan to institute our version of a stroke center. So we've been given some dedicated beds. There'll be 6 male and 6 female beds for our stroke patients, and we'll be training nurses who will be our stroke certified nurses. And so we're really hoping that we can now start to crack that 22% mortality and hopefully cut it in half or more again, just by caring for our patients in a centralized location with nurses who are well trained and well versed in stroke care. And looking forward to continuing to collect data systematically so that we can demonstrate the impact of that kind of what's called a simple intervention, but we know is not actually going to be simple when we actually start to put it in place.
Yeah, no, that's amazing work. And these complex interventions these bundled complex interventions are easy to say out loud, but not easy to do. So you definitely have your work cut out, but will have such high meaning. And, interacting with your team there, tell us about the bedsiders, the family involvement with sort of stroke activity, and how they get involved in stroke care for their loved ones.
Sure. So just to kind of give you a picture of our wards are big open spaces. They're divided into sort of 6-bed bays, but the bays are all connected. And there's about 45 or 50 beds in each of those 6 wards. And there's the nursing ratio is about 1 nurse per 6 beds, and there are really no nursing assistants. And so there's just not the staff for healthcare workers to provide a lot of what we would consider care that's provided by nurses or nursing assistants in the US. So family members are bathing, toileting, dressing, often turning, feeding patients. And so we've really taken a keen interest recently in trying to figure out how we can better utilize these caregivers who are just sitting by the bedside, really wanting to be useful and wanting to make a difference for our patients. And just to give you, I was struck by the fact that that the stroke patients at Hopkins spend 2/3 of their time alone. In our setting, there's a bedside caregiver next to the patients 24 hours a day, their entire admission, for probably more than 95% of patients. It's really an exception for someone not to have a bedside caregiver. And so really, these are people who care about the patient, who want the best for them, but probably don't know how to engage and impact their care. And so we started, one of our senior neurology residents did a project over the past year where he created just a very simple caregiver intervention to try to prevent aspiration pneumonia. So he had a 1-page handout on what aspiration pneumonia was. And then on the other side, 6 pictures of things that the bedsider could do when feeding the patient. So sitting them upright, trying to minimize distractions, a chin tuck while swallowing, things of that nature. And he basically spent kind of 5 to 10 minutes with the bedside caregiver going through this instructional handout. he left the handout and asked them, if another caregiver came in, could that caregiver who'd been taught teach it to the next caregiver? And we found that actually this intervention by itself, which essentially is free other than a photocopy, cut rates of aspiration by 2/3 in our population. And so obviously the caregivers were really motivated to implement the intervention, and it gives us a lot of hope that if we engage them and give them the instructions and how they can help us help their patient, that we can really make a big difference even when we don't have the nursing resources that a lot of other hospitals do.
This is why I love what we do, system science, to really show the effect of things that some might perceive as like, oh, that's kind of a throwaway intervention almost, but the power that it can have when properly placed with motivated team members. And the other thing is that, each person, as they're reflecting on their stroke center, probably has similar stories where their patient environment has a super strength that other places do not have, even in sort of high resource places. And really to harness the power of those strengths is really has such high value. And Betsy, what do you think of when you hear like all this sort of care partner discussion? And I'm sure you're having a lot of thoughts because your work has been a lot to investigate how people are perceiving their participation.
Yeah, thank you, Dr. Saylor, for those descriptions. I think the engagement there and having someone at the bedside who really who knows the patient, knows the cultural context, is so important. And it sounds like the culture there is a little different. Sometimes we're afraid almost to have family members involved. What if something happens? But I think you've described the incredible value in having family members involved. I was also wondering, you talked a little bit about the nursing training there. Can you talk a little bit more about how you envision having training the specialized stroke nurses there in your newly dedicated unit spaces?
Sure. So part of our stakeholder meeting in a couple of weeks will be to get nursing feedback on our proposals and what they feel they need and what would be most useful to them. But there are some really excellent stroke centers in sub-Saharan Africa who've already traveled this path. In particular, there's a stroke center at Korle-Bu Teaching Hospital that's been in effect since 2008. And they've really developed some fantastic teaching modules on the basics, manual repositioning of patients, continence, dysphagia assessment and management, communication, and all in a resource-limited context. And so we hope to not recreate the wheel completely and start with the resources that they've already developed, and then also contextualize those to our nursing staff and what they tell us they need as well.
Great.
Yeah, it's such an important element in the equation of excellent stroke care because, I often say the nurse is actually the center of the universe with the patient. They're 24/7 with the patient and their caregivers. And so it's really an important dynamic and one that has such high value. When we get letters of our stroke center care, it's always the nurses who are highlighted as, thank goodness for so-and-so. And many people on the team always given high compliments, but always nurses are at the center of those gratitude letters. And Betsy, I was really glad you brought up that concept of like feeling afraid of doing something wrong or afraid of making things worse. And, the family, I feel like that's kind of a difference in the two institutions that I'm getting the privilege of sort of hearing and seeing the evolution of stroke care. In the poem study where you talked with family members about their involvement, I feel like, some of the themes that emerged were actually fear that exercise would make things worse or fear of getting involved with it. Can you tell us a little more about what you've heard there?
Yeah, thank you for bringing that up. I think one of the so fear did come out. There was also this notion, particularly in this ICU phase, that they needed to just get through that, and then they could worry about this mobilization. They could worry about everything else. But there was this kind of this compartmentalization that we need to make sure that these life-saving interventions are are put into place and the patient is stabilized, and then we could worry about the other needs. And that was so important. That is so important for us to know, because in our conceptualization of the system of care, we would like to integrate all of that and integrate the mobilization and nutrition and all of those concepts, training for bowel and bladder habits and things like that. All of those essential needs that we have as humans, we can incorporate that in critical care and move that forward throughout the trajectory. So that I felt that was the right method to glean that important information from family members, so that we can design interventions, education to fill that gap.
And that's like such, our therapy colleagues are going to be able to comment a lot more. That's something that I know our therapists also have struggled with. Patients will say, I just don't feel up to it. I'm not feeling well. And kind of finding that threshold in the very early period of when to push a patient versus when not to. It's one thing when you have this perceived sort of medical stability and the patient's transferred out of the hospital. You can kind of push and motivate patients, just as our neurotherapists are trained to do and like perfectly expert at. But I also know that sometimes our team members are hesitant, like they are kind of sick, or, I really worry about pushing that patient, both the nursing and therapy staff. And so I know that's something that's come up in our unit huddles, where people say, like, I don't know, I also agreed he was probably really tired, and so kind of let him go today. So, there is a lot to learn from patient comments, care partner comments, but there will have to be some markers of like go, no go, like biomarkers perhaps, or hemodynamic markers. So what will you say, Betsy? You're kind of expert on this. What would you say to people as they're trying to find some objective markers of like when to push through the fatigue or when to kind of lay back? Because I think other stroke centers that are developing or using early therapy will probably have the same questions.
A great question. And I think, as you have stated so well, there's still more to be learned there. I think in terms of physiologic parameters, that's really kind of one of the main things that we have to fall back on in the hospital. What I would say, and what we've learned and what we've implemented, is more of an individualized approach, rather than saying that every patient whose blood pressure goes over 175 when they're moving around, which can certainly happen, has to stop. That we really need to individualize these stopping parameters according to what is safe for that particular patient, and look at their trends to figure out again what is safe for the patient. The other model that we have enacted, and actually this is based on another team's work in Florida, Dr. Titsworth and colleagues. They had an opt-in or an opt-out model. So every patient was and this is in terms of early mobilization. Every patient was evaluated for early mobilization unless there was a very specific reason and an order placed to opt out of the mobility program. And so I think that that has helped somewhat. We had some raised eyebrows of some of our neurosurgical colleagues when they saw a patient with a drain coming out of their ventricles and intubated and in a chair. And the nurses are very adept at making that happen, at making that transfer happen safely. And I think that it's kind of interesting how those accomplishments help the patient, help the nursing staff, help family members. Just seeing a family member sit upright and hearing you talk about, and Dr. Saylor, it's difficult to sit your beds upright. It really, when I was taking care of patients at the bedside more regularly, having patients sit up and put their glasses on, there was just something about that that made them just look a bit healthier, and oftentimes they were able to be more alert. So those moments are, we try to capitalize on those moments that are so positive and are kind of forward thinking for both the staff and for families. The same happens when we are able to walk select patients on a ventilator. It wasn't all that long ago that people would say that, you couldn't do that. That's not safe. But now we know that there are ways to do that. And again, those are kind of monumental accomplishments that the staff really takes pride in.
Those are such good examples. And, as we're thinking of that sort of grief trajectory of the shock of a stroke, that came out of nowhere for, people, everyone says, like, I just can't believe this has happened now. It is really, really important for sort of the emotional recovery. I'm glad you mentioned that. As I'm like sitting here, and I've thought this many times, and I think it's irritating when I say it out loud, but, here we're trying to highlight that there are high resource and low resource environments. But there are most days where I'm like, we are very similar to one another. Do you guys feel that way, or do you think that's just a half glass full lemonade out of lemons sentiment?
Well, I feel that with our staffing crisis, and when I heard you say one nurse to 6 patients, I thought that number was going to be even more. I mean, that on our floors, in some cases, that's not too far off. And when we think about barriers to delivering some of this mobility, early mobility and other types of care, staffing does come up, the acuity of our patients. So I was interested to hear that that really was similar.
Yeah, I think that's a great question, Mona, and I think I'm going to equivocate a bit because I think there are ways where we are clearly, I think the fact that we can't get a CT scan for several days and are making decisions about blood pressure and antiplatelets without knowing what kind of stroke someone's had, clearly we are, much less resourced than a place like Hopkins where things happen kind of instantaneously in comparison. But at the same time, I think that if you kind of have that perspective that there are barriers and things are hard here, then the things that can be done and that can be done very similarly here as in any hospital in a higher resource setting, they don't get done because you just think, oh, well, it's hard and we don't have this or this. And so we just can't do anything, and I think that is certainly not true. And that actually there's a lot that we can accomplish for patients, even if it looks a little different, or if we have to involve a bedside caregiver instead of a nursing assistant or something like that. I think that there's a lot that we can do, and that much of the day-to-day care can end up looking very similar, even if some of the more resource-intensive things, medication availability, investigations are not so similar. I think, as we've kind of dwelled on here, so much of stroke care is excellent nursing care. And that doesn't require expensive things for the most part, and so I think there is a lot that we can do in a lot of ways that the bulk of the care provided really does look the same no matter what setting you're in.
Such great points for sure. Let's talk now for a bit about research. So we know that without data and without our sort of awareness of our systems and our outcomes, we really can't make much progress. Let's talk for a minute about things that we know that we need and that we wish for in research so that we can learn what we're doing in different places and sort of standardize and move forward. Are there thoughts about research? Betsy, you have a biomarker background to look at like thresholds of exercise. Deanna, you have patient outcomes vantage point and implementation science. So let's talk about some research ideas and like how you've taken data collection as an important part of your processes. And Betsy, you're unmuted, so if you want to go first, go for it.
I can definitely start. Well, I think my interest has been, although I have gotten lots of ideas in listening to the speakers today, Dr. Krakauer and Felling and Dr. Hanley, and Dr. Lee, definitely kind of expanding ideas on biomarkers. But of course, we always, I think, as clinicians and thinking a lot about treatments, it's always nice to have a marker, a threshold at which you're targeting different interventions. And so in terms of mobility, I've been very interested in trying to figure out what could be better targets to titrate mobility interventions in this early period, practical things that ICU and acute care teams could target. Looking at larger data sets of the physiologic trajectories, blood pressures, heart rates over time, maybe that could give us better profiles of patients that do well at certain times with certain bundles of care, and those that don't do as well. I think in terms of collecting the data, I think we need to be very thoughtful about what we collect. As I have gained experience in the beginning, I wanted to collect everything, but when you collect everything, you end up not collecting everything very well often. And so I think being very thoughtful about what you collect, and then in terms of the trajectory of care, sometimes we have to be creative about how we can create additional data points. So for instance, in acute care, we collect vital signs less often as in usual care. But to study the effect of some of these interventions, I think we have to be a little more creative about how we can collect more granular data there. So those are some of the thoughts and some of the things I think that you and I have talked about. Are there devices that patients can wear that have minimal impact on bothering them or interfering with aspects of care where we could collect data and really look at patterns in larger data sets and look at outcomes. So those are a couple initial thoughts.
Yeah, and we're going to hear a lot more about wearables from Dr. French tomorrow, and there are lots more discussions on that and such good points. And really key statement of you don't have to collect everything to get started with data collection. And so I think that's such an important point, because some data is essential to know where you are in space, but too much data can be too overwhelming, and then no system can succeed that way. So I think that was such a critical point. And, there are some places that are going to be able to collect granular things, high-end things, but really it's for the point of informing every place about an important endpoint or important kind of clinical point. So, if we learn something at Johns Hopkins, it will be translated to other places so people can do better at the bedside in a really practical place. But Deanna, you've had some success of putting data together where there really wasn't that much data before, and in a continent that doesn't always have the best reported data because of, I don't know, capacity or reporting. But how have you perceived all this?
Yeah, and I think that part of that is that oftentimes people feel that research has to be the newest, greatest things that you're checking, the newest biomarker or the newest intervention. And so sometimes I think people get discouraged before they even start because they don't have access to the newest and greatest, or they don't have funding. But for us, our first study that really provided the bulk of the data, or all of the data that allowed us to get grant funding to continue the work, was literally conducted by a volunteer medical student with no funding whatsoever. And we just collected the clinical data that we were already gathering, which was very imperfect. Not every patient got every investigation we wanted. 15% didn't get CT scans, all of those things. It was very imperfect data, but just collecting systematically what we were already doing, it really informed our care. As you mentioned, Mona, I'm not a stroke neurologist and never was interested in stroke research until I arrived in Zambia. But our first study showed that 50% of our admissions were stroke, and that these patients were dying at really, really high rates. And so that just the need was there to better understand that. And so I think that it's so important for everyone to collect data, to understand where you are, where your touch points can be to improve care and improve outcomes, and that doesn't have to involve a lot of funding or even a lot of manpower or additional work, but just systematically capturing what you're already doing and asking meaningful questions. And I think for me, it's always important to ask clinically actionable questions. What can I change based on this question is really, really important. And I really think with a little bit of forethought, any institution can do that. And the other thing that, I was struck in listening to you talk, Betsy, is just talking to patients, right? And doing the qualitative work and asking them about their understanding and their needs, and often provides completely different perspectives than what you as the healthcare practitioner is assuming they think. And so again, everyone can talk to patients, and just start learning lessons from them that really inform how you provide care as well. I think some of our more impactful work has also been qualitative studies where we just asked, we asked patients, what are you worried about in going home? And, the answers astounded me. It wasn't the things that I was assuming they were worried about. And so I think not to forget that even just qualitative, simple, not that qualitative work is not simple, but simple questions asked through qualitative means can really, really inform practice as well.
Yeah, we talk about it a lot. We had focus groups many times, as Betsy and I have seen a lot of stroke centers develop over the decades here. And, hospital focus groups have really been informative to tell us what is our next priority step, so it's definitely important to get the lived experience. There are methodologies that make it really rigorous to understand that it's not just one person's opinion, but instead a very common theme. And so, yeah, it's really really critical to think of there are multiple ways to get to the information you need to make your center great. And, I always say, and, you're developing a stroke center, but the downstream effects of having an organized system for stroke patients certainly impacts other patients who are admitted with other diagnoses. We spend a lot of time on our dedicated stroke service diagnosing many other things. And so, it may be starting with a stroke center point of view because the data is so overwhelmingly positive that the stroke center is a treatment. But the indirect effects that I'm imagining that you're seeing, I think must be helping all patients who are admitted there with neurological conditions. So you brought up the transition home, so I'd be remiss if we didn't talk about that a bit, because I think that we've had visitors from Zambia, and when we sit and talk about, well, what are your observations from the visitors, they tell me we have a very different structure. Some places that it's kind of the physician tells the patient and that's it. Other places, the patient's included in the conversation. And I would say that at Hopkins, we've had kind of a bit of both, where sometimes we didn't include the patient and family early enough at all, except to kind of deliver information in one direction and make sure that we think people are understanding the information we're delivering. But I don't know what the best approach is. And both of you have different vantage points altogether. Betsy, you see all the communication in the neuro ICU. Deanna, you see communication from different types of providers to patients. So what are your perceptions on how we ready our patients to go home after such a stroke?
I think from the Zambia perspective, this is something that we are not good at this point, and it's one of the things that we really want to incorporate in our stroke center development. And I think one of the biggest differences between our system and many other systems is that there's no rehabilitation centers. So every single patient is, with very few exceptions, is going directly home after their acute hospitalization. And I think one of the things that we don't do well is make sure, and they're not going home with home nursing or any other really official support, they're going home with their family caregiver. And I don't think that we ready the caregivers well. I think that part of the stroke unit will be a skills checklist of things that we think the caregiver needs to learn in the hospital that they'll actually be able to continue to provide then at home. That's something we don't do and right now. And so I think that this transition home is really, really important for us to better understand and better prepare our patients for. We know, unfortunately, that after our patients leave the hospital, they die at really high rates in the next 3 to 6 months. And I think that a lot of that is that our caregivers are not ready for caring for these patients. At the same time, just like any other hospital, we have a lot of pressure to move people through the admission because our hospital is always full as well. So we can't keep them indefinitely and do the whole, 2-week rehab stay in the acute hospitalization either. But I think really purposefully integrating the caregivers early in the hospitalization in caring for the patient and learning from the nurses will be really important. At the same time, we've done a study here looking at patient preferences around patient-physician communication. And in most high-income settings, patients really value shared decision-making. And that is actually the lowest valued aspect of patient-physician communication here. The kind of a generalization is the patients say, well, you're the doctor, you tell me, what needs to happen. And so I do think that transition and those caregiver training still needs to be contextualized to the culture here and the expectations of a physician-patient relationship. But I think that we need to do a better job of involving caregivers earlier in the care of their patients.
Yeah, that's a really important point. In hyperacute stroke care, we get the same, we know that some people like shared decision making, but there are a majority who are like, I have no idea. You're the specialist. You tell me what to do. And there are other times where, people say like, I really wasn't involved in all the discussion. So I never knew how much you guys talked about or expected me to know about blood pressure management or these medications that I was taking. Yeah, people were educating me about side effects, but I just didn't really think about it. And then self-management becomes just such a critical point when people leave the hospital that sometimes patients will say like, I'm totally overwhelmed. So, we actually didn't do a very good job in Baltimore either with this transition in care. It's very siloed. Dr. Raghavan and I have talked a lot about this, like even handoff between the hospital and the rehab centers has been a bumpy road. It's never gone as well as we wanted it to. We've made great gains with some of our programs, but there is nothing, I think, more helpful than empowering the patient in whatever way they're ready to be empowered for their own management. And so I think that's critical how we think about that transition point from hospital, especially for we have about 50% who go home after a stroke, and how we help people to manage that life-saving event. Oh yeah, Betsy.
I just wanted to say something that came to mind is I think we definitely do need to continue to improve on how we involve family members and prepare family members and patients to go home. But there's something to be said for that experience. I think based on personal experience, you never know exactly how it's going to be in your house with your support network or without a support network to be with that patient in this new circumstance. And so I think we really have there's a lot of room for creative thinking, for collaborative work with patients and families on how we could do this transition better, because I think it really is going to take some things that we wouldn't ordinarily think of to really prepare patients, having networks that they can count on. We've talked about that, Mona and I, quite a bit, but things, there are just, I think the responsibility is something that you can't completely prepare someone for. It just feels different when they leave the doors of the hospital and go into their own homes. There are probably features of their home that they didn't even think about that would be problematic. And And so, you know, it's pretty complex when you break down all of those details. So I think that this is a huge area of need that really will require, does require a lot of creativity and collaboration with people who've lived it to come up with better solutions.
Yeah, you know, I will say we have made great gains with the J-STEP program. You know, we're really understanding that episode of care a lot more when patients go home. And they're feeling like they are not as abandoned. You know, patients told us that in the stroke center, they felt that the universe was like swirling around them and they were safe. And that when they got home, they thought, where am I? And patients just tucked themselves in bed and said, like, I don't think I can deal with this. And so then you lose a few more critical weeks of recovery where people aren't engaged because they just feel too overwhelmed. So I do think the J-STEP has been a really great ally for patients and identifying what needs they have, whether it's like a social work problem that's getting in their way, they didn't access their medications as we thought they did, blood pressures are out of control and they don't feel well. So I do think it's a tool. But as Betsy's saying, I think we need to also think about how the care partners join in terms of observations and data about what's happening when patients return to home, so we can really start digging in and understanding that episode. So I think some of those care partner studies are going to be really, really critical that are through the J-STEP program. Well, we're coming to our last few minutes, and I see our patients are joining in for the next session. And so I just wonder if you have any last minute thoughts, Betsy, Deanna. This has been a really nice discussion and great points that really tell people across the globe that it can be done step by step. Any last thoughts?
Definitely can be done. Thank you for moderating this discussion. It would be really interesting. I don't know if we have any comments in the chat, but so interesting, Dr. Saylor, to hear about your experience in Zambia. And I think, you know, to conceptualize the stroke units of the future in many areas is exciting.
Yeah, thank you, Mona, and thank you, Betsy, for sharing your work as well. And I think just, you know, ending on a note of encouragement that this can be contextualized into any setting, that you can always do something even without additional funds or additional resources. And then again, data can be collected anywhere to really inform your local practices as well. So thank you both for including me in this important panel.
Well, thanks, you guys. It was really great to be together, and thanks for all your comments and wisdom and for sharing. And if people have any other questions or thoughts, feel free to drop them into the chat or the Q&A box. But we're to the top of the hour, so we're going to pivot now. I see that some of our patients have joined us, and we're going to have a chance to have a discussion, and Dr. Zink, you're going to be leading that. So thank you so much. As I mentioned in your introduction before, you're really a wise leader in this field of sort of navigating the hospital system and critically ill patients. And I'll look forward to the next hour. So take it away.
Thank you so much for that introduction and for our last hour's moderated conversation. So I welcome our patients. If you want to, our former patients and so I see Maria on the screen, and Antoinette is here, and maybe a couple of others will join us as we go. And I think I might also see a care partner on the screen as well. So, so it's my pleasure to be able to moderate this session, and really all that I really do believe in patient-centered care. All that we are talking about today, a lot of great science was discussed this morning, a lot of mechanism, but at the end of the day, it's all to make people better. And it's so wonderful to see you on the screen, to see you in your own homes, because that really is what it's all about. And so, so I wanted to start just to see if you could introduce yourselves, just a brief introduction, and then we'll get into a couple more questions. But I can't thank you enough for being here today. Maria, did you want to start?
Yes.
introduction?
My name
Okay.
is Maria Braga. I'm a professor in a medical school. I'm 63 years old, and I just had a stroke on the 29th of April.
Wow.
And this is my wife.
Okay, so nice to
She's
meet
the
you.
one who called 911.
Okay, all right, nice to meet you. And your name is, or just so I can make sure I call.
Oh, Camille.
Camille, okay, so nice to meet you, Camille. And Antoinette, and I hope it's okay, we can refer to each other by our first names. Betsy is fine with me. Antoinette, would you like to just do a brief introduction?
Sure. My name is Antoinette Gordon. I had my stroke in 2020, I believe. And my daughter was the one who saw my facial expression and called 911. I'm working today, so I'm in one of our conference rooms, so forgive me. I'll turn the mic off because we have airplanes flying by.
Okay. That's wonderful to see you at work. And so thank you for those introductions. And I wanted to start with the first question just about your experience. And you've talked a little bit about how your stroke was recognized. And we work so hard to get the message out for family members. Even in schools, we've had experiences where young children have made the identifications that you described, that they find that the face doesn't look like it normally does, or someone is having trouble talking or moving one side of their body. And so if you could talk a little bit about the experience of when you knew something wasn't right, and you entered our stroke care system. Maria, did you want to start?
Yes. So mine was very recent, just the end of April. And I had a surgery, a lung surgery. And I recovered very quickly, and they sent me, and I felt that I was doing well. So they sent me home. I was home for 3 days, and I was, feeling better. And so I was going to make lunch. Camille was downstairs watching TV, and I said, please would you time the oven? And as soon as I finished saying that, I noticed I was standing, and I noticed that something was wrong. So I had the presence to walk to a chair just in time. I got to the chair, and by the time I sat on the chair, I could no longer speak, and also I could not move my right side. So I sat there, and then luckily for me, Camille came up right away. And then she came and she said, well, you said, you needed to, and I could understand a little what she was saying, but I couldn't answer back. So she looked at me, and I think she saw, and she can report herself, that my mouth was a little to the side and I couldn't speak. I tried to say something and nothing came out. And she knew right away I had the stroke. So immediately she called 911.
Okay, and then what happened when EMS got there? I'm sure, just based on personal experience, it probably felt like quite a long time. Hopefully it was minutes.
Yeah, so to me, I even talked to my neurologist about that. For some reason, I'm gonna just say, I'm a Buddhist. So I think it's because of my training as sitting in meditation, stuff like that. I was calm all the way through. I knew that I was in trouble, and I saw when they arrived, and I knew that they're collecting information from Camille, and I just sat there calmly, and even thinking, we just recently moved to a new townhouse. We're trying to size because of our age. There are many trails here, and I'm thinking, we just moved here, and I'm not going to enjoy, my house anymore. And they put me on the ambulance. And would you like me to say the whole thing, how I went to the hospital?
Sure.
So they put me on the ambulance. They moved me from my chair to another chair. They put me on the ambulance. That's when I said, oh my God, we even painted the front door red. I love that red, but that's it for me. I'm thinking, So they flew me to, they actually drove me to the hospital in Frederick, the emergency room. And then in Camille can record what happened there, because by then I'm on my back, but I knew that they're running, and I think I was a little in and out. I'm not sure that I was completely there, because I don't remember having the scan in great details like I do when I have scans. So, and then by then Camille had called a couple of friends, and my best friend is a neurologist at my university. We teach together. So she called the emergency place, and they were trying to decide, because I had had surgery. They thought that having, to blast through the clot wasn't a good idea. And, so they decided that they're going to fly me either to the University of Maryland or Johns Hopkins. And to my luck, my best friend plus my wife said, all of our doctors are at Hopkins. And if they have a room there, if they're ready for you, they'll fly you there. So I was aware, and they put me in the helicopter, and I thought, God, I never wanted to be in a helicopter, but that's the time to be in a helicopter, And I kept my eyes closed most of the time because I couldn't move much, and so I get to Johns Hopkins, and I could tell that they unloaded me from the helicopter, and they went through the doors, and I knew that I was in a corridor, and they wheeling me. And then I noticed that I became sleepy, and I thought, yep, they're gonna anesthetize me now. And then I was out. And then when I came about again, I was already in the ER, and I was already recovering. So the team there at Hopkins, I have to say, I have no words, it's fantastic. Yes.
Well,
I mean,
thank you.
they tested me several times, and on the second day I was already talking and everything. I have nothing. I have no deficits.
That's
No.
amazing. What strikes me, and thank you so much for describing that in detail, what really strikes me, and for all the clinicians that we have on the line, is you were in there, and we are often trying to organize things very quickly and talking over people. But I thank you for your such a detailed description, because that really teaches us how very important it is. I don't know if you have any remembrances of
I do have
talking to you.
remembrances. Yeah, they talked to me. Everybody was very kind all the way through. And I knew that they needed to communicate among themselves.
Yeah.
I knew. So basically, I sat there, I lay there, and I was hoping for the best. And I had the greatest trust on you. Wasn't I right? I was right.
Thank you. Thank you. So Antoinette, and I'll definitely come back. Thank you for the detail, Maria and Camille. Antoinette, what on those lines, what was your experience kind of when your daughter called 911 and then coming into the hospital?
My children were having a birthday party. So it was my nephew, my son's girlfriend, and my two daughters. They were downstairs. I was in my room watching TV. And my youngest daughter came up to ask if I needed anything. She would always come check on me. And I said some ice water, and I handed it to her, my cup. And she looked, and she started screaming, Mommy's having a stroke. Mommy's having a stroke. But in talking to her, I could hear my voice, and it did sound a little slow. But in my mind, it sounded as if I was speaking correctly.
Mm-hmm.
All I can hear was footsteps running up the steps, everyone coming in, my nephew telling me to sit down, Aunt Ann. I said, I'm okay. He said, no, Aunt Ann, you're not. And my son's girlfriend was calling 911. Well, my daughter called, but then she went into hysterics. She's very hysterical and anxious. She was over in a corner. I could see them trying to calm her down. The ambulance got there very quickly. My nephew was talking to me, keeping me calm. The The paramedics came upstairs and they were talking to me, and all I remember saying is, somebody please get Kiev. Someone, that's my daughter's name. Take care of her. That's all I could think of, is her in the corner crying hysterically. And they said, she'll be fine. You go with them. And we went downstairs. I remember going downstairs and talking to them. And I'm telling them, I'm okay. I felt fine. It was like, no, ma'am. They took me in the ambulance. They asked me which hospital I wanted to go to. I told them Howard County, because my records are there. We get there. It's a gap. I don't know what happened once I got there. All I remember was being rolled on a gurney to the helicopter. And unlike you, Maria, I've always wanted to ride in one. I remember saying to whomever it was I was talking to while I was in the helicopter, of all the ways to get a helicopter ride, and I'm not going to remember it. I remember saying that, and they chuckled. And we arrived at Johns Hopkins. And after that, I don't remember anything until I awakened later. And everyone's in the room looking at me and asking me questions. And I'm like, I'm okay. They're like, no, Mrs. Gordon, you had a stroke. You know, I'm like, I feel okay. And they would tell me to do the fingers like this and stick your tongue out. They were very attentive in making sure my motor functions were intact. And like you, Maria, I didn't suffer any deficits. Thank God for that. Yes. So that was my experience, Elizabeth.
Well, thank you. Thank you for those details. It's so important, I think, for us as clinicians to really hear, and interesting to hear what you experienced at the very beginning. I was wondering for each of you, what with this global audience of clinicians, what do you think, is there one thing that you would tell us to really keep in mind, a key point to keep in mind when caring for patients with stroke, from your perspective?
You say.
Can I speak?
Sure.
Okay. So, you know, I was kind of there throughout the whole thing, except for the helicopter ride. They wouldn't let me on that. But, you know, the ambulance ride and into the hospital and then going to Hopkins and things like that. One of the things that was concerning, I guess, or was the important decision, was what kind of treatment that she was going to get. You know, we basically had a couple of choices. One was to blast it out, or, you know, to dissolve it with the heparin thing. And then the other one was to do the lobectomy.
No, lobectomy.
I'm sorry, not the
Thrombectomy.
Thrombectomy. Yeah, that was before. And so, you know, speaking with the doctors there at Frederick and trying to discern which was the best way to go. Fortunately, I guess for me, because of her and also because of my own background, I was able to understand a lot of what the doctors were talking about. But it's a lot to absorb. It's a lot to try to understand. And they were saying, we did the scan, and, you know, and they were talking about her heart, and there was like multiple kinds of things that were going on in addition to the stroke itself. Now, Maria couldn't speak.
I was totally disabled.
You know, was kind of immobilized. She really couldn't move.
I couldn't
around.
move, yes.
She couldn't speak or anything like that.
It was a major stroke.
Yeah.
They had to kind of speak for her and understand, I think, what her needs were going to be in order to translate that to the doctors in terms of what I thought we would want her to do, or what we would want to have done. So as soon as we got to Hopkins and they let me in to see her after the surgery, you know, there was a lot of, she had her own nurse, which I thought was just fabulous. She was in the neuroscience critical care unit, which was really awesome. And everybody that came in did that thing, right? what's the date? What day is it? What month is it? What year is it? But like about 50,000 times.
Yes.
She got
The
better
Antoinette endorsing that.
every single time.
But I improved with every visit.
And I think what I was really happy with is that there were like a flow of different doctors coming in. I think at one time I went out to use the restroom. I came back, there were 7 people. And but
You're fantastic.
they communicated
Fantastic.
and allowed me to communicate with them what was going on and what was happening and things. So I felt involved and I felt more secure. Now, of course, they didn't give us any real promises. I said, you know, how long will this take for her to,
Nobody can.
and they said, well, it could be 3 months, could be 6 months, could be a year, could be whatever. Well, it was
Or it could
like,
be 3
it
days.
was like 24 hours and she was completely coherent and speaking. Yeah, so I guess I kind of got off a little bit on that, but what I meant to say is the communication is very important.
Mhm.
And she could understand, she just couldn't respond. I knew she knew what I was saying. I could tell she knew what I was saying, but she, you know, to have somebody communicate with you in such a way that you understand what's going on, because there's a lot of things going on all at one time.
And having proximity to her seems to
I
have been
tell
very
you,
important as
yes,
well.
just to include this, on my part, I understood once I woke up and they start talking to me, I understood everything they were saying. They were so kind, so thorough. And then I recovered so fast that I became nervous. I thought, geez, I'm like an extreme case. And the other thing, the reason why I'm saying this is because it made me nervous. When the neurologist came back to see me and I asked him, so kind he was. He said to me, no, don't be nervous. 10% of the patients like you recover like that. So that calmed me down, and no longer I was nervous about it. And only gratitude. What I have is a huge amount of gratitude because I have my job back and I have my life back.
Well, thank you. Thank you for that. Antoinette, any key point that you would want to impart to us as clinicians?
Actually, yes, there is. The most important thing that I want them to know is just because an individual has a stroke, the results or the aftermath of having it isn't central line to everyone. Everyone's bodies are different and they respond differently. I'm sorry, I talk with my hands. And one of the things that I had trouble with was they were viewing me as if I had deficits that I didn't have. So everyone may not, maybe that's what I'm saying. Everyone does not suffer the same type of deficits. And to gauge where each patient is, don't categorize us all or don't box us all in one category, because we're not all going to have suffered the same type of effects of the stroke. That's my biggest takeaway for you guys. Don't think all of us suffer the same way.
Thank you.
Okay.
I'm going to say thank you. That's exactly, it was another thing that I would say too. One of the things about Maria, she is a full professor. She's she teaches neuroanatomy. She's a neuroscientist, and her level of recovery is, we were expecting like a high functioning level of recovery. And so when people were asking her questions and things like that, I'm saying, you got to ask her something that's more appropriate also to her. Like, what are the nerves in the face? What are these? So this is how
You want to make it harder for me.
well, I wanted for them to understand the level at which the expectation was set for her in her recovery, not just that she knew what day and everything it was and say, oh, that's great recovery.
But they did do that.
Sorry.
They did when,
Oh, that's okay.
Yeah, when they did that, they did start talking to me. They asked about the nerves, you know, and then I said, I'll test you now.
Yeah.
It was fun. It was
Yeah.
really nice, very nice.
That is a good point. Thank you. That we need to meet you where you are individually. Thank you for
Yes.
that. Thank you. Now, I have gotten a chat that maybe we have had another patient join us. I don't see her on the screen. I don't know if any of the conference organizers can assist. Should I be seeing her on the screen?
Thank you, Betsy. They're going to promote Ms. Sweeney to join you guys in the conversation. And I'm just
Okay.
sitting here admiring this conversation so much that, you know, these insights that Antoinette, that you shared, that like, don't assume anything, you know, about an individual is so critical so that we can do our best job for every single person. And, you know, Maria, I never thought about that fear that must come with like, wow, that surgery helped me recover so quickly. Maybe that's not normal. And maybe there's going to be the other shoe dropping and maybe I'll get worse again. So
Yes,
I was really thinking about that. I hadn't thought about that.
doctor, you read my mind. This was the thing for me. It was like, oh my God, I'm recovering so fast. Am I going to, something else is going to happen to me again? And he came. I mean, your team, doctor, let me just say, I'm so sorry to be like this, but it just happened to me. And I feel so grateful, forever grateful. Your team, to me, saved my life. Fantastic team. They were so good in so many aspects of it. That me, you know, yeah, I'm funded by the NIH. I just renewed my 5-year award. So I need my brain. You imagine that my whole team depends on me. We do research in the area of epilepsy and boom, my brain is taken away. You and your team did it for me. So I'm grateful, grateful, grateful.
And I'll chime in on that too. Yes, Dr. Bahouth. So am I, forever grateful. You had an excellent team.
Thank you. Well, we're so glad that, and we want to constantly improve. I think I speak with Dr. Bahouth when we want to continually improve. We're never happy with where we are. We always want to get a little better for patients like you and to provide better outcomes for even larger numbers of patients. And so thank you for your help today in helping broaden this discussion. I wanted to move also to during your stay to talk about your experience with therapies when you first started doing therapies. What was your experience there? Or moving around with the nursing staff and moving with the therapist.
Antoinette, do you want to go first?
So for me, in the hospital you're speaking of, is that correct, Elizabeth?
Yeah. Mm-hmm.
I welcomed it. They were very attentive, very concerned. So I'm a good patient because I want to get better. So I'm going to follow the instructions and directions, you know, and this was something new. So I was in 100% to make sure, like Maria was saying, your brain, you want to have full function of your brain, and whatever it took to get it there, I was willing, and I wanted to learn more about what happened to me.
Mm-hmm.
You know, so I was asking questions and they were very patient and willing to explain it to me until I understood.
So to me, after they moved me out of the ICU into a regular room, it was just like a regular. I mean, I had the neurologist still coming and talking to me, and again, very grateful. I talked to one again about, you know, I had several questions. You know, I will start worrying about depression. Am I going to have depression after? Your team answered all my questions, and in fact, I went back home very quickly. So it was as expected, and the level was still maintained very high.
Great. Great. Well, I want to also welcome Ms. Sweeney, Ms. Bridget Sweeney here. My name is Betsy Zink. So nice to have you. And I see that your daughter is here as well. Hi, so nice to meet you. So we've been talking just about the experience of having a stroke and coming into a system of stroke care. And Ms. Sweeney, and if it's okay to call you Bridget, we've been using first names. Feel free to call me Betsy. We understand that you entered our system from quite a long ways away. Do you want to tell us your experience of coming to us from Bermuda to Johns Hopkins?
Yes, I had been in Bermuda for a week, of which should have been 3 weeks, visiting my son and his family. And I did not have a lot of the stroke symptoms per se. I started vomiting very early in the morning and just could not stop. And I actually was in a home that was not my son's because they had an air conditioning malfunction, and they were like, "Oh no, we want you to be where you're comfortable." So I called them up and said, "You need to come get me. I'm throwing up. I can't stop. I don't know what's going on." And they got me. You know, my son left work and picked me up and took me back over to the house where, I don't know for sure when I talked to you, Kelsey.
You were texting me all morning. I couldn't understand your texts. So
I could not text. Nothing made sense.
so we said to get you to the hospital.
And
Okay.
luckily, my kids know a couple doctors at the hospital there. There's only one hospital in Bermuda. And I went to the ER, and I don't remember most of this. This is, returned to me via people who were there and saw things happening. They got me there and said, "We don't really have a neurology department. We can't treat you here."
Right. And they had, but they do work with people from Hopkins. So they
Yes.
were communicating with their liaison there and said, "Hey, like, we think this might come to the point where she needs surgery and she'll certainly need more care. So we want to try to transfer to Hopkins." So we arranged a
And
ambulatory flight.
yes, I flew on a private jet for the first time ever, and I don't remember any of it.
It wasn't a really super nice one, I don't think. I saw the picture. It looks like, glorified cargo.
It was close, yeah.
All three of you have had flights into Hopkins. We have 2 helicopter rides and a private jet now. Wow.
Oh, all got to fly in.
Yeah.
Well, from what I understand, when I talked to Dr. Bahouth the other day, she was one of the people who helped kind of arrange that whole, how do we get her here? We want her to come here.
Yes, telemedicine.
Yes, I didn't know that, but yes, so grateful. And I'm sure you all saved my life. I don't know what happened. Like I said, when I was there, I did actually go to Bermuda recently and talk to the doctor who was the one who said, bring her in. But I didn't ask him any of the details, so I don't really know that either. But I don't recall being in the ICU at Johns Hopkins, but I guess I was there for a week, about 10 days. And then I went to the recovery unit and was there for about 4 weeks, 5.
Went to the brain recovery unit, and then you went to the inpatient rehabilitation, and that's where you were for about 3 weeks.
There you go. It was a long journey.
But we saw each of the units.
We did. And I had a lot of support, not only from, the doctors and therapists there. I had a lot of support from family and friends. You're so confused. Your brain is not working right, obviously. And it was, if you can call stroke a good, feel, I felt very observed, and anything that I could have asked. Unfortunately, I didn't have a lot of questions because I was not really thinking that much, to be very honest. I was just kind of there.
I'm glad I am so glad as a nurse to hear all three of you talk about your experience of being cared for. That's very important to us, that you do feel cared for and you feel observed. That's one thing that we do in neuroscience, nursing and neuroscience units. We observe you, we do neurologic assessments very frequently. And I can imagine they can become quite annoying, but it's very interesting that you also felt cared for in that as well. So let me switch a little bit to the transition time. Now, I believe two of you went home, and Bridget, you went to the rehab and then went home. Could you talk a little bit about the preparation for going home? Did you feel prepared to go home? What did it feel like when you finally got home after that discharge?
I was very, very excited. And the thing that was really amazing is I got to go home on my birthday. So that was awesome.
Yeah. Well, originally they talked about maybe doing additional inpatient just locally because we're in Roanoke, Virginia. And we had been talking about that in like the 3 or so days leading up to discharge. And then I honestly can't remember who suggested it, or if it felt like a combination of people who said, I think recovery might be better at home. I don't think, we need to do the additional inpatient. So, and they talked me through a lot of the transition and what, I needed to be able to help make
This
her
woman
transition.
is my hero because she's the one who stayed with me 24 hours a day for the next 2.5, 3 months.
2 months, yeah.
2 months, yeah.
Wow.
I can say that I knew nothing about anything to begin with, and I felt, both. I had to I got very technical information, but I also got some pep talks because, quite frankly, I was freaking out.
Yeah.
Because I'm like, but I'm not I'm an accountant by trade. I don't know anything about what, I should be
a caregiver.
Yeah, a caregiver. And I felt like the communication was very helpful.
She did a great job. She took me to all my therapy visits and made sure that I ate and didn't sleep too much because I really had a great deal of somnolence. Is that what it is? I was so tired all the time. All I wanted to do was sleep.
Okay, so you had a lot of fatigue, and we do hear that in patients that have had patients after stroke. How long did that last? That fatigue, that just
I
profound.
still feel fatigued, but I'm not sure that it has to do with the stroke. The fatigue I felt with the stroke was I would be talking, and the next thing you know, I'd be like snoring. Almost narcolepsy kind of thing.
Well, Antoinette, were there any surprises when you got home? Anything that you felt maybe that you weren't prepared for in the hospital, or maybe was talked about but was a little different?
Not that I can say any different. No, like I said, I was one to follow instructions because I was afraid, because I didn't feel any symptoms. They saw it when it happened to me. So everyone was hovering over me, and I kept telling everybody I'm okay. And I think it scared them a little, them being my adult children, a little more than it scared me, because no one wanted to leave me by myself, and I was the child and they were the parent, but nothing that I can recall, nothing out of the ordinary. No, it just prompted me to change my eating habits because they thought it was high cholesterol. And when I left, they told me they still weren't actually sure what happened.
Okay.
So I took that step to try to do better at what I ate.
Okay, yep, controlling those risk factors. That's great. And I hear that you are one of the stalwart members of our educational sessions, that you try not to miss an educational session. So how have you used that? How has that played a role in your recovery? The educational sessions with Amelia.
With Amelia, I enjoy them because I take what they tried to teach us and I try to implement it in my life. The only thing is the timing. Sometimes I work since, well, mine happened during COVID. Now that everything has opened back up, I go to work and I get off right before they start. So when her sessions start, I'm usually in traffic. So I have to figure out how I can set my phone up to just at least listen, because a lot of times I may miss it. I only catch it when I'm off work or teleworking. But I get a lot out of the different speakers.
Okay. To hear Maria and Camille, how was the transition for you to home? Was there anything surprising? And maybe the experience was a little different for you, Maria, than it was for Camille.
And as you can imagine, I'm learning until now, because Bridget said something about feeling tired and sleeping a lot. And even though I recovered completely, now I was sleeping, I was feeling tired. I'm not sure, because I had the lung surgery too, shortly before that, but I did, and I'm feeling stronger and more alert with every day. I have a very active life, so I would walk for an hour a day. I was doing hits and stuff. So I have to say that my level of activity was very high. And since I had the surgery, and thus immediately after the stroke, I have not been able to keep up with my level of activity. However, I'm doing walks now. We went canoeing today. And regarding coming back home, I think that listen, my therapists at Hopkins, before I was discharged, they came and they tested me for function, everything. They were fantastic. And then they told me I had no deficits. So I was happy to come home too. But as soon as I got home, I was grounded by Camille. I couldn't go anywhere. I couldn't go down the stairs when I woke up in the morning without her. Everything was I still can't drive because the MVA has restrictions. Talk about that, huh? I have to work on that a little bit, because I'm working from home, but eventually I have to go back to the university. So, but overall, considering everything, and every time I remember how it was when I had this stroke, I just get very happy, and no complaints. And I understand Camille's point of view.
Well, we have a little different perspective.
Yeah.
Right. And so when they released her, I mean, I was surprised that they were going to release her so soon, but I was there when they did the evaluations and things, and she was walking around and talking and doing very well. But I noticed a few things that she doesn't seem to think are apparent to her. There were some bouts of forgetfulness, maybe a little distraction, not being completely grounded, and I don't know if that's relative to the stroke or pretty much all the excitement and everything that happened within the last 2 weeks. But her focus seemed to be a little
sparse.
She had a little hard time focusing on certain kinds of things. But for the most part, her conversation was okay. She actually started to sleep better, because up to that point she had not been sleeping very well. And of course,
because of the surgery,
watching all the time, because she had surgery, lung surgery as well, and so I was concerned. And one thing she didn't mention, but that Antoinette mentioned, is they have not discovered what caused the stroke. They did an echocardiogram of her heart, they checked her legs, they did this, they did that, all these things, and have not come up with the cause, which is concerning to me, because then I think, well, if we don't know what it was,
It could happen
It could
again.
happen again.
Yes. And unfortunately, that is a proportion, quite a sizable proportion. When we look at the causes of stroke, we call it cryptogenic stroke, where we're not able to identify that precise cause. And I'm glad that you brought that up, because I have often thought that must be frustrating. Not to, sometimes scary to know the cause, but to not know the cause.
But guys, remember, this was 2.5 weeks ago. So I still have to go see their tests that I'm still doing.
Okay.
So eventually, I think I'm hopeful that they will be able to come up with the etiology of the stroke.
And Bridget, and I'm sorry, I didn't get your daughter's name.
Kelsey.
Oh, I'm sorry. Can you say that one more time?
Kelsey.
Oh, Kelsey. Okay. Sorry, I wanted to be able to call you by name. So Kelsey, was there anything when you did mention that you really appreciated the kind of the truthfulness and forthright way that things were described to you? Were there any things that were surprising to you, things about the house that you hadn't taken into account that affected your mom, or you felt pretty prepared?
I think Mom's got a house that's over 100 years old, so we kind of knew that our work was cut out for us.
Wow.
I think I can't really think of anything that was like that surprising. It's, obviously we continue to do like the therapy after we got back, and I think there are some additional like tips and tricks that were picked up along the way through like occupational therapy, like putting post-it notes up.
Okay.
It may have, honestly, it's one of those things where it's like it very well was brought up to us when we were still at Hopkins, but it's just, when you're drinking from a fire hose, there's only so much you're keeping
Yep.
top of mind. So I think part of that is just, breadcrumbing it out for us to.
Well, there's so much that
To
you
know.
can take in.
Yeah.
I one of the things that I was very curious with during the rehab is I kept having therapists say, "You're doing such a great job," but I didn't know why. And I finally started asking, "Can you quantify that for me? What exactly is it that I'm doing that you're so impressed with?" Because for me, I just don't know how to feel. And they did that here in Roanoke as well when I went to therapists, and I kind of said the same thing. And they said, when we looked at the information regarding, your stroke and where you were and how it, came to be that you actually got over back to the States, there was a lot of questions about whether or not you would continue to live. So, and I just was like, oh.
That is one thing that I was surprised about, is some of the memory loss, which like it's like I knew, you can objectively, you can be told like there's going to be short-term or long-term like memory disturbances, but experiencing it with somebody who you're not used to having it, I feel like that is a completely different experience. And yeah,
I have a whiteboard that I keep for my doctor's appointments and groceries that I need to pick up and different things like that, which has been very helpful.
yeah.
My calendar is totally filled in, it feels like, but that helps a lot too. And the notes have been wonderful because I go out for little short walks, but I still kind of have a little balance issue. But I'd walk out and not take my cane, for example, and being in a neighborhood that is a century, in the process, there's a lot of sidewalks that don't quite,
Sorry.
Oh, bless you. And putting the notes up has helped a lot.
Yeah, the post-it notes, it says cane and that sort of thing.
Yeah. So.
And thank you. I think both of our caregivers, Camille and Kelsey, you have nicely illustrated that there's a reversal where there wasn't necessarily a caregiving relationship before. After the stroke, there was a little kind of change in roles. So thank you for illustrating that. We do hear about that and think about that a lot. And Kelsey, your description of drinking from a fire hose, we often worry about that. There's so much that we want to give you, but you're right, there's only so much you can absorb. And I see, Antoinette, you probably felt that as well. You're shaking your head. We do have a question from the chat. Can the panel speak to the emotional impact and any emotional changes since the stroke that you've appreciated?
Well, I can say that because I have always been a very upbeat person. It's my nature, you know. So even when I have a bad news, so I had the bad news of the lung cancer. For you to have an idea, in 2 days, I had already reversed that into, it was a good thing because we caught it early and I'll survive. And apart from that, I can prepare myself. We all live as if we're going to live forever. That's the Buddhist point of view. And I know I will go. So I switched that around. And I tell you, it was fine. I was fine. I'm still fine with my lung cancer. But with the stroke, it was a little tough for me for the first few days because it's not that I'm going to die. It's like they're going to take away my ability to speak. They're going to take away my ability. And even though I didn't, I was a little nervous. So I talked to the neurologist about that. And they said there was a clinical trial. They are trying this antidepressive drug that they wanted me to test if I wanted to take it. And I said initially yes. But then just as usual, as the more I talked to the neurologist and they explained, I understood that instead of being upset about it, I should be very grateful. Because here I am, I'm talking, I'm moving, I'm able to discuss, I'm presenting data at work. And so I decided not to take anything because I'm back to normal, close to. But it does cause a little depression. It did cause a little depression on me that I had to work on.
And it's interesting that you compare the two disorders, your lung cancer, and that was something that you were dealing with. But the fact that the stroke would potentially take away your faculties, it was just different. So thank you for describing that. Bridget, were you going to answer the question? I'm sorry.
Oh, I kind of, had this mild depression creep in. I don't know about what point, but, when I came home, I was like, yeah, I'm well, I'm better, I'm here. I get to wake up in the morning and talk to the people I love, and was so grateful. And then kind of slowly it just, got a little grayer. And I did talk to my doctor, my internal medicine doctor. I didn't talk to my neurologist about that, but they did suggest, that I try an antidepressant, which I am currently taking, which is okay. They kind of overdosed me on that antidepressant, and I had a really tough couple of weeks seeing things that actually weren't there.
My goodness.
It was awful. Yeah. And going and telling a doctor, I have this odd thing happening when I go to bed. I wake up in the middle of the night and there are people standing around in my room. So they took me down from the dosage, and it took a week or two, and I'm all over that now.
Good.
I think if I may.
Yeah, go ahead.
I did notice with it seemed like, yeah, you were really happy when you first got back, and then kind of like the reality of continuing to have to do therapy and having to find different approaches to things that you could do without a thought is kind of what kind of started grinding you down.
It's daunting.
Yeah, it's daunting. And I think you were concerned about whether your personality had changed. I think that especially in the beginning, that was something that you were, rightfully so, fearful of that potentially changing. But
well, and I'm sure it has, and I still sometimes dwell on that a little bit, but this is what it is. And I have gone to talking about myself as Bridget 1.0, and after the stroke, I'm 2.0.
I love that.
So, you know, best I can do, and I'm doing my best. That's what
Yeah.
counts.
Bridget, I wanted to ask one question. Did you use the video gaming or animation game when you were in the hospital? Do you remember anything?
Good.
about
I
that?
had a dolphin. What was his name? Bandit.
Bandit.
Bandit the dolphin. Where you'd go and you'd get fish, and you know, it did help you with your right and left. And it was suggested that I had a left side deficit, which makes sense. My stroke was right here.
Mhm.
But it was a fun way to, you know, kind of get that visual sense and the dexterity. I laughed and I said, you know, when the kids were little, I used to cheer for them. They'd go, come watch me play video games. And I said, I never was a video game person, but I'd cheer for them. I said, I need them here now to cheer for me. And they were there, so.
Antoinette, did you have any words? Did you want to respond to the question from the chat about the emotional response?
Could you repeat it again? I was trying to find it so I could read it. Could you repeat it
Oh,
again?
sure. So the question was about could the panel speak to the emotional impact and any emotional changes after the stroke?
Okay. I, like Maria, have always been positive and upbeat person. So I continue to be that. I think it was the fear from the family around me, friends and family. And for me, I think the fear came in when, say, I had a headache, and immediately my head would go to, oh my God, am I getting ready? Am I gonna have another stroke? Take aspirin or Tylenol, and it would go away. And I learned to calm down and not panic immediately. You know, that was, I think, for me, the worst part. You know, you're always on guard because you don't know what caused it. So you don't know if you're doing something that could trigger it again. But I can't honestly say I ever felt depressed. It prompted me to do more things. I like doing cryptograms, always have. So I found myself doing more of those type things that would cause me to think and to use my, kind of keep me alert and active, more than usual.
Okay.
You know, to keep me active. And we would go for walks, just talking and walking, you know, my friends and family and I. But I, for the most part, I stayed upbeat. I don't think it saddened me. I was grateful that I was still here to talk about it.
Yes.
You know.
Well, thank you all for all of your observations today and for a window into your experiences with your stroke and with the care that you received. I just wanted to make sure that that Maria, I believe Bridget saw it, but one of our speech therapists, Kelly, wanted to say hi. She cared for bothRia and Bridget. And
Hi, Callie.
Kelly.
Oh, she was fantastic. She is fantastic.
One from Minnesota.
I don't think.
Yes.
let's see, maybe she'll respond.
Could be. I remember somebody from Minnesota. Michigan.
Michigan. Yeah. Well, I think Dr. Bahouth has a couple of words to wrap up. And again, your experiences are invaluable here to us as clinicians. So thank you so much for your time and for your thoughts today. It's been a pleasure to be your moderator.
Thank you, Betsy.
Well, thank you so much. You're getting rave rounds of applause because there's nothing more important to us than knowing your experience of having care received through our stroke center and your experience so that we can do even better every single time. And when I look at this screen, I see like a bundle of fierce women, all of you. So really kudos to you all for taking this beast and just smacking it in the face. I heard such great themes here. You know, Maria, you had a surgery that helped you recover very quickly, which was great on one hand, but scary on another. All of you felt like you had lots of people around you, and often, you know, you wanted to make sure people were very specific about the things they were telling you, whether it was instructions that were good or bad. Antoinette, told us about the experience of like knowledge is power, and like going to kind of take your health by control and coming to these J-step education sessions to really keep yourself strong. All of you flying from wherever you landed for stroke care, and your family members who have been such strong forces of good for you to both call 911, get the right care that you need, and just advocate with you and next to you along this path. So congratulations to all of you, and thanks for sharing your time with us today. That was really critical.
Thank you.
Thank you.
And I will just say we're going to wrap up for today. Tomorrow we restart again at 8 o'clock with opening comments, and the day 2 will kick off. And I have to say, I'm utterly amazed knowing where most of these participants have come from across the globe. Some of you, it's 3 o'clock in the morning. I'm seeing your names and knowing what time it is in your neck of the woods. So I commend all of you for persevering, and thanks for being with us today. We look forward to seeing you again tomorrow. And thanks everybody. We'll hang on the line in case anybody has any last questions or comments, but thanks to all the speakers today and the panel participants. You were wonderful.
Bye-bye.
Dr. Bahouth, may I ask a question before I go?
Oh, please.
Well, what's going on tomorrow? Is it a continuation of today with different groups of patients?
Yep, tomorrow we talk more about rehabilitation and our systems of care, our therapist teams. There will be a lot more content tomorrow, and please join us again using the same link if you'd like to join tomorrow at 8 o'clock.
Okay, I can just listen in because I might be working, but I could listen.
Yeah, you can join in, same link, and just you'll keep your camera off and enjoy the content.
Okay.
And I see a lot of comments to use. One saying thank you all for sharing and stay blessed and be well. That's a nice parting comment.
Thank you. Thank you for asking me to participate. Thank you.
Thank you for sharing your thoughts.
Have a good day, everyone.
Bye, everybody.
Bye.